Good evening. Welcome to this group discussion on intestinal stoma. Before I talk to all of you about the subject proper, there are certain things that I would like to digress a bit deliberately, because any teaching session must not only teach you and me, it's equally applicable to the teacher as well as the student. The topic, of course, we have to learn about the topic, and how extensive it is something that depends on the type of teaching. But it'll also tell us uh, things that are needed to make us teachers. All of us are students and teachers at the same time. So today I'm the teacher and you're a student, but tomorrow you'll be a teacher and I can well be your student listening to you. So you must, apart from focusing on this subject, you must also focus on how to structure your teaching session, how to structure it, number one, how you make slides, and how you present it. Okay, those are things, and you keep looking at your teacher and learn how that person is doing it. And that learn is in inverted commas, because any teacher may be good at certain things and not so good at certain other things. So you will watch him, apart from listening to the subject, the other things that I mentioned, and you learn some nice things that he say, oh, I should also do it like this. And if he's goofing up, doing something not so nice, then you should tell yourself, oh, I should avoid this. You need not air it and insult the teacher, but think it within yourself that maybe I should avoid this. This doesn't sound very good. So that kind of thought process must be going on in all your minds when you're listening to a lecture. Okay, to help you focus or root you in that direction. Nikita, it's a question for you. If I asked you to give a talk on intestinal stoma, can you tell me a few headings under which you prepare your talk?
So, anatomy of the small bowel.
Okay.
Anatomy of the bowel, sir, first.
Okay.
Then history of stoma.
Okay.
Indications of stoma, complications of stoma.
Right.
Management of the complications.
Right.
And I think so. In your recent advances in the stomas management, recent guidelines or recent advances in stoma.
Okay. I think that's a very good kind of approach. All right. So we'll get into the subject proper now. One of the important things about intestinal stoma is its significance. That's why I asked for 2 classes, not 1, because it has a high complication rate. You must start by understanding that anywhere between 20 and 70%, and a reasonable average is 40, has complications. And so there is a lot to learn about how to do it properly. And if you have a lackadaisical attitude about fashioning a stoma, then you'll be in trouble. And it's very important, because even a very good quality stoma has significant impact on quality of life. So you must understand what impact it has on the quality of life of the person. And if you have a complication on top of a stoma, it will be really, really very bad for the patient. And it also has significant psychological and social consequences. So the point here is that we must really understand how a stoma is constructed, what are the limitations, what are the principles we must have in mind. And it certainly is not a situation where an experienced senior, leaves it with a junior who doesn't have experience to fashion it and go away. Many times, a stoma is fashioned at the end of a long procedure, at the end of a long operation. So it's very tempting for the senior to just unscrub and leave it to a registrar or a senior student to do it and go. That's the last thing a senior must do. Okay, what he must do is stay back and see the youngster through the procedure, reiterating the principles of fashioning a stoma, and then leave. That's a very, very important lesson for all of us. I'm reinforcing it for myself, And I'm telling all of you because you are the consultants of tomorrow. Have that in mind when you do it. So as Nikita said, we are sort of doing the same things here. I'm not going into the history of stoma. I'm not talking about anatomy because that will make it even longer than what it already is. But we must have a definition and understand the classification or the types of stoma. We must know why we do it at some length in the technique, even though I keep saying that the technique has to be learned on the table, but the theory behind the technique is something that we're going to touch upon. We'll definitely talk about the complications. As I said, there are quite a few complications. We will discuss at length some of the complications, not all of them, because some others are either rare or not too consequential. So we may gloss over those with constraints of time in mind. And finally, the timing and the indications and the complications, technique and complications of stoma closure. Once you have done a stoma, there are situations where it may not be permanent, and so we look at stoma closure. So this is not for today. The whole thing is for 2 classes, but let's see how much ground we can cover. All right. So we start with what a stoma is. So whom shall we ask? Supreet, you've read in that paper. What is a stoma?
Sir, exteriorization of the small bowel or large bowels.
Okay, only those two?
Through anterior abdominal wall.
Only through anterior abdominal wall? Ramesh?
Hello, sir.
Yeah, how do you define a stoma?
Sir, it's an artificial opening to
Mhm.
exterior abdominal wall
Mhm.
or to drain content from tubular structures, sir.
Yeah. So why only abdominal wall?
For drainage,
Can it be elsewhere in the body? Can it be in the lumbar region? Can it be in the neck? The answer is yes. Okay.
Yes.
The important thing is, this is a surgically created communication between a hollow viscous and the skin to reroute the contents. Okay. So if you have a hole in the abdominal wall, which is spewing bowel contents, is it a stoma? It could be artificial, need not be natural. Is it a stoma? Praveen, quickly. It's not, it's just a fistula.
no, sir.
It's just a fistula. So the important thing is that it is surgically created. Artificial is, even a fistula can be artificial. It need not be natural. When you have a post-op fistula, it is artificial. It's not natural, right?
Yes, sir.
So a surgically created, okay, communication between a hollow viscous and the skin to reroute the contents is a stoma. Okay, and so while we are primarily dealing with GI stomas today, also understand it's a hollow viscous, so you can have a urostomy, you can have a nephrostomy, an opening of the pelvis to the surface, you can have an opening of the ureter to the surface. They are also stomas, okay, but we're not dealing with it today. All right. So if you look at the classification of stomas, you can look at it in very many ways. So, tell me some types of classification with examples of stomas that you know of.
Sir, gastrointestinal is ileostomies, colostomies, and double barrel, and in ileostomies, end and loop.
This is a very, very haphazard way of listing. I have repeatedly told you people, you must look at the headings under which you give any kind of description. That's when you remember it the most and you also understand what it is. Okay. First of all, when you talk about, say, colostomy and ileostomy, what are you talking about?
Gastrointestinal.
Is it gastrointestinal? Only? It's an organ. All right. So depending on the organ that you're bringing out, it's something
Yes, sir.
like that. Are there any other things that you can think of in a stoma. You've seen enough stomas in your life, I'm sure, in the 3 years that you have spent. Only GI I'm talking about. Sorry?
Urethrostomy and tracheostomies.
Right, but I'm talking about GI only now. I told you, no? We're
Double
talking
barrel.
about GI. So what is that called? Let me help you. Let me help you with it. Organ involved. Give me examples.
So colon and ileum.
All right. Okay. Esophagus,
Stoma.
esophagostomy, stomach, jejunum, ileum, colon, ureter, kidney. List goes on. Bladder. All right.
Yes.
Yeah. Perineal urethrostomy, urethra. All that can be done, but I have mentioned these. Like that, can you think of something else? Nikita? I'm giving you examples. Duration that the stoma exists.
Permanent or temporary, sir?
Correct.
And next one would be the end or loop.
Location.
Location,
Right?
yes.
It comes a little later. Yeah, I mean, that's also true. But what, depending on location, what would you think of? It's not rocket science here. You've seen all this. It's very, very simple. It can be neck. It can be in the epigastrium. Okay. Right upper
Yes,
quadrant, right lower quadrant, left lower quadrant, lumbar. It could be location, anatomical configuration. What do you think of? And loop,
double barrel.
double barrel, flush, pouting. Example of a flush ostomy.
In colostomy, sir.
Yeah, and pouting.
Ileostomies.
Yes. Purpose.
Diversion or
Diverse. End.
Decompression, diverting, and protecting. Decompression is when you have some kind of inoperable obstruction. Proximally, you decompress it as a first stage many times. You can divert it completely. For example, can you think of a diverting stoma? When you want the fecal stream to be diverted from something?
After repair of fistula, suppose if there is a rectovaginal
It is a, yeah,
fistula.
it is protecting, right? That's protecting. Yeah. So complex perianal fistula, okay, probably secondary to inflammatory bowel disease. That is diverting. You have a very, very bad perianal sepsis. You drain it, you know, and you want to divert the fecal stream from there. Yes, after sorry.
Resection of bladder, diverting urine to the intestines.
Yes, but as I keep saying, today we're talking about GI.
Okay, yes.
That's why I didn't get into that example. But yes, that's also true. So protecting is when you have done a low anterior resection, low rectal anastomosis, or a coloanal anastomosis, or a repair of a rectovaginal fistula that Nitya mentioned. So those are the three main ways in where you consider purpose while classifying stomas. What about timing? Emergency in plan. There's a lot of difference between the two. That's why people consider this, and we will touch upon it when we go along. And it could be either laparoscopic or open surgery. Stomas can be created either at laparoscopic surgery or at open surgery. So if you see, a very simple thing like a stoma can be considered under so many headings. And it's good to have this kind of organized knowledge so that you can think of all aspects of stoma surgery. Okay? And depending on what we have learned so far, I want you guys to describe this stoma completely. Supreet, let's give it to the youngest person. What does this picture show?
So end colostomy.
All right. What else can you describe in that from the picture?
It is not an emergency, sir. Planned.
You don't know that really. Yeah, you don't know that.
It's in left iliac fossa.
Good. Location. You're thinking straight now already. That's good. It's a left iliac fossa and colostomy. All right. Next. What is this? Go on.
Loop,
right.
loop.
Again, why are you incomplete in your, when it's a left
Left
picture
iliac
shows
fossa.
you, it's a left iliac fossa, right?
Sir.
The left iliac fossa,
Loop.
colostomy. Okay. And what are these three different, there are three different things. What are they? You can't give the location because you don't have a, a perspective view, but it will give you a cross section. So you must be able to describe each one of those. What is the top one?
End or loop
It's
colostomy.
not end.
Loop
It cannot be
colostomy.
end. It's a loop colostomy. What's the next one?
End colostomy.
Yeah. And this?
Double.
Okay. So this is Nitya, you're not working. Right.
This one, yeah.
Okay. No, I'm pulling your leg. Yeah, you got to be awake. Yeah. So this is a double barrel colostomy. All right. So that is the way you understand the terminology that we employed when we classified the types of stomas. Now, for the seniors now, let's keep them a little busy. Nitya, tell me some principles that govern the indications for a stoma. You actually covered it already, but go on.
Depending on the type of organ, the principle varies, sir. So basically, if it is a colon or an intestine, the way we fashion it, if
No, I'm
it's a
talking about
colon,
indications. I'm not talking about technique.
indication if there is an emergency obstructive pathology, then also if there is any, when we are doing an anastomosis and if there is severe sepsis and we can't do an like we have done a resection and we could not do an anastomosis,
Correct.
then
Correct.
that is when. And
Yeah.
also in case of healing process,
Yeah.
we will.
Actually, I told you, we already mentioned it already.
Yes, sir.
Okay. So it's either to relieve distal obstruction, inoperable cancer, or left-sided colonic obstruction, you want to do a transverse colostomy or an ileostomy. Divert fecal stream. We talked about complex perianal fistulae, for example, or even or enterocutaneous fistula. So if you have a enterocutaneous fistula, proximal to that, you want to divert the fecal stream so that you give that fistula a chance to heal and protect distal anastomosis. We actually mentioned it. That's what I said. Those are the principles that I was sort of thinking of. So when you have these principles, then you talk about indications. Basically, we're talking about colostomy and ileostomy, that they're the two common GI stomas that we fashion. What would be the indications for colostomy, Nitya?
Sir, one would be, if we talk in terms of the protective one, then we can do if there is a rectovaginal fistula, we can do a sigmoid colostomy as a protective one.
That's if you repaired a rectovaginal fistula. Okay, agreed. Yeah.
And if it's an emergency, if there is the obstructive, if there is a CA descending colon, then we can do a transverse stoma after the resection.
Correct.
And if there is a diverticular disease, and after resecting the diverticular segment, if the sepsis is very severe, then we can do a stoma.
See, that's the kind of general trend. I agree. So end colostomy, you can think of it as end colostomy and loop colostomy. End colostomy when you do a Hartmann's, when you do an APER, or you may do it for fecal incontinence when it is irreparable. And if you have very severe radiation proctitis, for example, you'll end up with an end colostomy. Defunctioning loop colostomy, relieve distal obstruction. It could be malignant or inflammatory. Again, complex perianal fistulae that we mentioned about, fecal incontinence, and emergency management of anastomotic leak, or to defunction an intestinal fistula. So these are the common indications for colostomy. So if you remember those two principles, protective stoma, defunctioning stoma, and diverting stoma and defunctioning stoma. if you remember these three principles, you can think of the various indications. What about ileostomy? Vinod?
Again, sir, these are all we generally indicated mostly for
Mention a few diseases here under those three headings. I want, because when you write an exam or when you answer in a viva or even think of those three headings. When would you do an ileostomy? When would you do
as a protective for
protective?
anastomotic leak in the colon?
Okay, in the colon. Okay, good.
And for again this intracutaneous fistulas and
yes.
And when there is a radiation proctocolitis.
Yeah. When is it an absolute must? An ileostomy. See, logically, you must think like this. When is it an absolute must? When you cannot have a colostomy. What are the situations when you cannot have a colostomy?
Radiation proctocolitis and ascending colon involvement.
No, yeah. When you do a colectomy, yeah.
No colon.
When you have no colon, where can you do a colostomy?
No, sir.
So what are those situations where you must mention that first for ileostomy? Others are also acceptable, but I'm just saying, think of it logically.
Ulcerative colitis and FAP.
That's it. Yes. That's all. Simple. So if you think like that, it's very easy to write in your exam also and remember practically where it is required. So whenever there is a total colectomy or a proctocolectomy, as in FAP or fulminant ulcerative colitis, okay? When a colectomy is done, you have to have an ileostomy. There are other indications. Wherever you do a colostomy, you can also do an ileostomy. We'll think about which one of them is better, if at all. There's some learning to be done about that. But here, as I said, a loop ileostomy can be protection for distal anastomosis, to relieve obstruction, particularly if you have an ascending colon blocking carcinoma, which is unusual. It's the descending colon that carcinomas that block a lot more. Emergency management of an anastomotic leak and the severe radiation proctitis and sepsis in the perianal region, like Fournier's gangrene also, and necrotizing fasciitis and things like that, where you do not want the fecal stream to go over that area. So these are the indications for ileostomy. Okay. And as I mentioned, there are certain, if you saw that list of indications, there are certain areas where both ileostomy or colostomy can be done. And the question normally logically arises as to which one is better to do. And if so, why? And before that, I would like you guys to think about what are the factors that you would consider before you home in on one or the other. Sanya, what are the factors that you would consider before you want to choose between ileostomy and colostomy?
So
for
first
covering
is,
an anastomosis, yeah.
Yes, so the indication for why we are thinking about ileostomy or colostomy, if it is somewhere like you said, sir, if colectomy is done and we don't have a colon, then we have to go for ileostomy.
No, I'm not asking that. You have the colon, either this or that can be done. In which case, what are the factors that you would consider before choosing one or the other?
Depends on like where exactly is the disease, sir. If it is
no, that's not the point. Think of other things, yeah. For example, I'll start you off. How easy is it to fashion?
Yes, sir. Ileostomy is, yes, sir, easier.
We'll look at it in other ways, but first let us look at all those headings. How easy is it to fashion? How easy is it for the patient to manage?
Yes, sir. And
okay.
Closure.
How easy is it to close? Okay.
Yes,
what else? What are the complication rates between the two?
Yes, sir.
All right. So all these things have to be considered. So when you, again, I'm stressing it and going back to the basics. Okay. Going back to the drawing board, as it were. When you ask a question, Okay, you must be looking for all answers for all these questions. You must have logical questions. It could be anything. So don't blindly mug up something and repeat it. Okay, so think about it in a logical fashion. You will understand that you will then look for information to answer those questions. And as I said, if you do not have information, you create a paper, that's a subject for a paper for yourself, for research. And if you already have the answers in the literature, you learn about it and look at it and get an answer. So if you look at it that way, okay, this is a very recent paper, 176 colostomies, 234 ileostomies. Okay. Now, if you have, there was a higher retraction rates if the stoma existed for a longer period and it was done in women. Ileostomies had a higher output of, as we know, in the first 48 to 72 hours, they have metabolic problems. And with that dehydration, they can get into trouble. All other factors that I mentioned, how easy is it to fashion? How easy is it to reverse? What are the, we learn about complications perhaps in the next class. So what are all other factors were the same. And so what this paper concluded is that basically it is left to the surgeon to choose either an ileostomy or transverse colostomy, for example, in protecting a left-sided colonic anastomosis. Avoid ileostomies if there is any renal function compromise, because these guys get dehydrated. And avoid colostomies if you're fashioning it in a woman, and if you envisage, the stoma to be there for more than 4 months. But if you think you're doing it for 2 months or something like that, if the renal function is fine, and even in females, for example, it's just your choice whether you want to do an ileostomy or a colostomy. Okay, I'll stop here and invite comments from Niranjan for what has been said so far. Niranjan, are you there? Okay.
Hello.
Ravi? Okay, you're there. Yeah. Any
Yes,
comments?
sir.
Any comments?
Nothing, sir.
Niranjan? Yeah, nothing.
Nothing, sir. Nothing, sir.
Okay. Ravi?
I think just to reiterate your point that after a long surgery, kindly stay back and help your, as registrar or whoever is doing. It is nice for them to do it, but you have to be there, teach them, and make sure it is done properly. It is. I think patients don't accept stoma that easily. It is a crime to create complications because of your, as you have said, lackadaisical attitude. Sir, one thing I just it's a, I don't know whether it's an observation, but somehow the Western surgeons tend to prefer ileostomies and Indian surgeons tend to prefer transverse loop colostomies. Any particular reason for that, sir?
No. I have looked at this debate for 35 years. And very strange, you are quite right. Westerners tend to do ileostomies. But strangely, the 5 surgeons that I worked for in the UK, all of them preferred colostomies. All of them. And their single most important point was that it was easier for them to manage a colostomy rather than an ileostomy. And technically, it is easier to reverse a loop colostomy versus a loop ileostomy. Okay. And so most of the people I worked for, and I practice the same thing now, is do a transverse colostomy whenever possible. Of course, if there is a need, there's an ascending colon obstruction or no colon or a leak from a right colon, I'll definitely do an ileostomy. But my first go-to stoma is a right transverse colostomy. What is your practice?
I tend to do ileostomy because that is most of them whom I trained with did ileostomy.
They did ileostomies. Okay. All right. Any comments or questions from the students, registrars?
Technically, sir, while doing technically, is it loop ileostomy is easy or loop colostomy is easy, sir?
Let Ravi answer that.
Sir, I think it is surgeon's choice because if you are used to doing ileostomies, you can do them easily. Right. Similarly, if you are used to doing colostomy, you can do them easily.
Yeah, but I do believe that even theoretically, if you have a loop ileostomy, to make a spout of it is a little more difficult than doing a flat loop colostomy. If it's
Sir,
an
what
end,
about
if it's an end
sorry, sir.
ileostomy, it doesn't matter. But when it's a loop ileostomy, getting a spout for the afferent side, where the business end, as we call it, where the bowel content comes out, getting a loop on that side, it's not, it's not terribly difficult, but it's a little more involved than doing a loop colostomy.
Yeah, I
What
agree
about
with you.
reversal,
Wait,
sir?
let Ravi finish here.
Sorry, sir.
I agree with you, especially if there is, obstruction and bowel is,
Inflammation,
edematous
edematous
and
bowel. Correct.
inflamed, thickened. I think
Correct.
then it becomes very difficult to do a
Yeah.
loop. It swells up also, and
Correct.
ultimately it looks like a dog's dinner, though it
Correct.
may work later.
Yeah, Vinod, to answer you, reversal also, it is, I think, more involved to reverse a loop ileostomy than a loop colostomy. But as I said, those differences are minor, and it is left to the comfort of the surgeon to choose one or the other. Comments?
One more, sir, sorry.
Go on. No more, sorry. Go on.
Yeah, because when we are doing the reversal, there is a chance of a resection of a segment of bowel. So when we are going to do an end-to-end anastomosis, what we read is anastomosis wise, small bowel have a good healing capacity when
correct.
Yeah.
Correct.
So how to even till now, I am thinking that small bowel is the best choice when going for a loop ileostomy.
Yeah. As I said, the leak rate from the closure of an ileostomy or the colostomy is the same. And in a loop ileostomy, when you reverse it, it's extremely rare that you have to do a resection. So bowel compromise, vascular compromise is non-existent unless you are dealing with ischemic bowel. Okay. So that is not where theoretically your point is well taken. In practice, that's not a major issue. Okay.
Sir, I have a doubt, sir.
Yeah.
Why is it that this paper they have mentioned to avoid colostomies in females, sir? Like any reason?
As I said, retraction rates are higher in females in the colostomy version.
Why is it
Probably
so, sir?
because of obesity. I mean, I'm guessing it. They haven't looked into why it is so. You can
Okay.
all retraction rates are generally higher in people with thicker abdominal walls.
Okay, sir.
Yeah, and that would probably be the reason. Yeah.
Okay, sir.
Yeah. Okay, so we now move on to the technique of doing a stoma. And when you're looking at the technique, you have to look at certain aspects of it. Siting of the stoma, where you site it and why you site it there. We have to look at the technique for colostomy, ileostomy, and very briefly about gastrostomy, that is open gastrostomy, and very briefly about tube cecostomy. We will basically focus on these two. Okay, so when we consider siting of a stoma, okay, Sai Likit, I see, has joined. Sai Likit, did you read the paper that Madam sent you? I presume Madam Nikita sent you the paper as well as to Supreet. Did she send you a paper? Are you there?
I put it in the group, sir.
Group, okay.
All of them. Yes.
So you would have, he's not responding. Are you there? Can you unmute yourself? All right. He's not there. Supreet?
Sir.
What are the things? Did you read anything about how to cite a stoma?
No, I didn't understand.
Didn't understand. I agree. Very good. Ines, I have not asked you a single question today. Very bad of me. Tell me, how do you cite a stoma?
So we'll take into there'll be factors that we'll take into account that it should
Go on. Tell me. Don't dilate. Tell me what are the factors. We know.
For the patient, sir.
Sorry.
Comfort of the patient, sir. First, it should be accessible to the patient without any difficulty.
Okay.
Then
good.
it should it should be away from any bony prominences or umbilicus. It should always be lateral and inferior.
Umbilicus is not a bony prominence. It's a scar.
Yes.
Yeah. So bony prominence is?
Like the ASIS, sir. Or,
yes, or a costal margin. Yeah. Okay.
So it should be away from those, sir. And
Should not be on any fold, sir.
Yes, it should not be on folds. Good.
They should be able to sleep comfortably, sir.
Yes, sleep. Okay. You should be able to see it well, right?
Visible, yes.
So in what position would you mark the stoma?
So it
What
should
position of the patient? He should be able to sleep well. So would you do it when he's sleeping or do it
No,
when
sir.
he's standing?
sitting position.
In a comfortable sitting position.
Sitting
Sitting,
or
standing,
standing.
and
He should be vertical. Okay. All right. What else would you think of?
Squash,
Almost
our
covered the
fold.
whole lot of it, but there's one more thing you guys have missed. Can he put his waistband or a
belt
belt
lines.
over the thing?
Belt, sir.
Ah,
No, sir.
yeah. So the first thing you must start with when you're citing a stoma is to start with counseling. First, talk to him. Tremendously important. Emergency, of course, you have no chance. You're doing an emergency operation, but in fact, not most, all of the planned operations, you must sit with them and talk about it. Involve a stoma therapist if you have one. Most of our hospitals will have a stoma therapist. If your own hospital doesn't have one on the payrolls, you'll always find one in the city or the town somebody who has interest in stoma. And if there is one such person, call that person. If there is nobody, you are the stoma therapist. So it should be visible, easily visible to the patient. So the patient must be standing or sitting also is okay. It must be a flat surface. It has to stick nicely to the skin. So if you have, that's a point that Samir made, correct point. It can't be over creases and folds. It must be away from scars. Umbilicus is a scar. A laparotomy incision is a scar. It should be away from bony prominences, as I mentioned. It should be away from ASIS and the costal margins, for example, in the upper part of the abdomen. And it must be away from waistbands. So these are the principles. So you guys go and talk to the patient, sit with him, spend time, and do the marking. Okay. And when you are actually fashioning a stoma, what would be the principles that you would follow? Samir.
Sir, like the technique, sir? Or?
Like
So,
the adequate length.
Where we are? We are in the technique part. That's why, yeah. Accidentally, I almost gave you the answer. Yeah, go on. Stoma principles. I'm not talking about individual colostomy or ileostomy, but there are some principles that govern the fashioning of a stoma. Okay, you started Ines. Go on.
Like mobilizing it well, sir.
Yes, correct. There should be no tension when it comes through. Correct. Good.
And ensuring that there is a good, adequate blood supply to it.
Very good.
And the aperture, sir, like the aperture size should be appropriate so that it's not too small or not.
Neither. Excellent. Okay. So never bring out the stoma through the main. Sorry about the spelling. Okay. It's wound. It should be not wound. 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 Except in a mucus fistula. Okay. Never bring out the functioning stoma through the main wound. There should be an adequate opening in the abdominal wall. Neither too tight nor too loose. The general guiding principle is it must be about 2 fingers breadth. You avoid kinking and twisting. The bowel should come out in a natural, smooth fashion from within the abdominal cavity to the outside of the cavity. Vascularity, as you mentioned, must be maintained. And after you fashion it, examine for easy passage of a finger. Many times you can have a kind of a blockage, semi-blockage at the fascia, level of the fascia, or just as it is entering the abdominal wall at the peritoneal level, you may have a kink, which may prevent the easy passage of your finger. So it's always good to check that before you do that. Okay?
Sir, and also efferent and efferent, sir. We need to make sure which is the proximal and distal end.
Correct. In a loop ileostomy. Ileostomy, that's very important because your pouting should be on the afferent side, the business side. The efferent side can be, that is the non-business end, can be flat with the surface. You're right. That's particularly important for loop ileostomy. So this is how colostomy marking actually looks. This is the waistband that is marked there, and you can see it's about halfway between the ASIS here and the umbilicus. This is for a left iliac fossa colostomy. Somebody who was more artistic, like one of my youngsters, this was a marking he did for a laparoscopic APAR. Okay, so we have marked the ports that we're going to put in, and he's put a mark there for the waistband, and he has put this marking for the stoma. I do believe it's a little too high, and as it actually happened in that case, I got this down about 1.5 centimeters below where this mark was, because I felt at that point in time that he was very close to the waistband. Okay, so that is the kind of typical marking that you do. Okay, and we've looked at the principles that we follow when we do it. And the technique of doing a colostomy, you at the marked site, you take out a circular ring of skin. You are protecting the undersurface when you are doing it all the way through, so you don't want to go too deep too soon. There's a lot of controversy as to whether you should only cut the fat, subcutaneous fat, in a cruciate manner, or whether you should take out a disc of the fat. Some people take out a disc, others don't. But either way, the fascia is cut in a cruciate manner. That is the anterior rectus sheath. And the rectus muscle is split. It's not cut. It is split in the direction of the fibers. Then you're on to the posterior rectus sheath. You cut that and the peritoneum in one go. And then, as I said, stretch the whole passage to accommodate 2 fingers breadth easily. Okay. And when you pull it out, you have to have all those issues in mind. Egress through the abdominal wall must be smooth and non-kinky, as it were. Adequate vascularity. There should be not too much bleeding from the skin edges. There should be no twisting. And as Nikita rightly said, the direction must be okay. And there must be, I'm repeating it here, adequate lumen at the facial level. Okay, so this is a picture of a classical colostomy. You can see here that this edge is sort of turned on itself and the 2 layers are sutured. I don't do that. I just do the full thickness edge of the bowel onto the full thickness of the skin. There is no mention of sutures at the facial level. Many authorities recommend, and I do it too. I take a few stitches, 3 to 4 stitches around the circumference for both ileostomy and colostomy at the facial level, and make sure that the bite on the bowel is seromuscular and not too deep. Yeah. If you do it full thickness, you may end up with a fistula at that level. So make sure that you take a seromuscular stitch only at the facial level. This particular picture, they have not shown a stitch at the facial level, but I always do that. To some extent, one can claim, I have not seen any evidence, randomized controlled trials and things like that. It can help with both prolapse and, more importantly, retraction of the stoma. Okay, this is how a good colostomy looks like. A slight pout, absolutely no, very well vascularized and nice and circular like a flower, as it were. And there is no stenosis, there is no retraction, there is no ischemia. This is how a good colostomy looks. Okay, there are certain authorities, some authorities who recommend an extra peritoneal passage for the terminal part, 3 to 4 inches of the colon. One of the reasons for this is that you can have, when you do not do this, there is a small incidence of a hernia between the colostomy that comes straight out and the lateral abdominal wall. And to avoid that, at a more posterior level, that is 3 to 4 inches on the side of the lateral abdominal wall, you create an extra peritoneal tunnel and then you bring it out and you stitch up this area where you have raised the peritoneum onto the lateral abdominal wall. By that, you avoid this hernia, but the incidence of that hernia is so low that I have not practiced it ever. Okay, and there is also a concept of a hidden colostomy, which I have never done. But the idea here is that if you're mostly done for an anastomosis, distal anastomosis as a protection, you do not give him a stoma, bring the two loops out through the abdominal wall, and the skin is intact. The whole thing is under the skin. And if the stoma leaks, you don't have to do a laparotomy or anything like that. You open the skin and, what you call mature or make a hole through the colon, mature the stoma. If everything is smooth, leave it as it is. Do nothing. He may have a little bulge under the skin. As you can imagine, it's not a very attractive proposition, and I've not done it. But if somebody asks you what is a hidden stoma, this is what it is. Okay, that's what it is. We then go on to ileostomy, but before that, comments from the teachers here. Niranjan first and Ravi.
Hello?
Yeah, go on, Niranjan.
Sir, nothing, sir.
Yeah, is there anything other than what I have said that you do?
Nothing, sir. Same, sir.
Same as, yeah. Ravi?
Sir, I think the colostomy, you've shown a very beautiful colostomy. I think, for ileostomy, what you do is you take the.
We'll talk about ileostomy later.
No. Just in comparison.
Okay.
Ileostomy, you take the mucosa and the edge of the stoma, and then go 4, 5, 6 centimeters in a seromuscular stitch, and then onto the skin.
Yes.
So that will take the pout. So
Yes.
instead of taking such a long thing, I just take the bowel, and then about 1 or 2 centimeters below, I just take a couple of bites. That is not for all of the stitches, only 4 of them, and then onto the skin. So it gives a small pout so that it avoids 1, retraction, and 2, it will ensure that the bag is nicely placed onto the stoma.
Sure.
Which
Okay.
is simple. It's a simple thing, but I agree with you. This hidden stoma, I think one of my consultants used to do. I used to always fight with him, because I said it would actually
side
act
of
like an
abdomen.
obstruction. Because if the bowel swells up, it will actually cause an obstruction, and it will defeat your purpose.
Right.
So, and it never actually, one patient did go for obstruction also.
Okay.
So we had to then undo it. So I think it is probably mentioned to be, I wouldn't say condemned, mentioned just to be mentioned. That's all.
Okay. So,
Sir,
Sanya, go on.
I have 2 doubts in colostomy, sir.
Yeah.
One is when we are doing a loop transverse colostomy,
Yeah.
there's the greater omentum that is attached to the transverse colon.
Yes.
Do we separate it and bring out the loop, or should we make an
Absolutely.
opening? Okay, sir.
Absolutely. Separate that segment where you're bringing out the colon.
Okay,
You have to separate the greater omentum.
Because I had read in a few places where they said you have to make an opening in the omentum and then bring out the loop.
Yes.
Can we
Yes.
do that?
You
Like
can,
opening in the omentums.
You can, but the downside of it is that it will be a very bulky egress. If you
Okay,
just
sir.
make a small opening to just bring out the colon, okay,
Yes, sir.
through that opening, then it will be
Opening.
very bulky. You're pulling up the greater omentum also.
Up. Okay,
Yeah,
sir. Okay.
I'm not saying you excise it. I'm saying you separate it for a good distance on either side of
Distance.
where you're bringing out. So
Yes, sir.
that bit of the omentum falls away and stays deep
Below.
to the peritoneum and doesn't have to come up with the bowel.
Okay, sir.
Only the bowel must come through the layers of the abdominal wall.
Yes, sir. Sir, and another image that you showed where you were talking about the seromuscular stitch,
Yeah.
the stoma looked like it is coming out of the main wound. Is it because of some indication, sir, or
No, where? This one.
this one here, sir?
Yeah, no,
Is
no.
it the
This
main wound or
this is not the
colostomy
main
closure
wound. It's a colostomy wound.
Okay, sir.
What they have done is that to make the colostomy, they have not taken out a disc like people usually do.
Okay, sir.
But
So
they've
they've made
a
a
linear,
transverse.
yeah,
Okay, sir.
they've
Okay,
made an
close to-
oblique or transverse incision, and they've
Okay.
closed a bit of that wound and then brought out the stoma.
Brought out.
It's
Okay,
not
sir,
from
okay.
the main wound.
Yes, sir. Okay.
Okay. It's
Sir,
never brought out through the main wound.
Yes, sir. Yes, sir. Except
Go
the
on.
mucus fistula, you said,
Correct.
sir.
Correct.
Yes.
Correct. Yeah.
sir,
Go
about
on.
this
One
again
last
in
point.
transfer.
Ravi, go on.
one last point. I think Vinod asked which is easier to do, transverse colostomy or this one. But I think that question is kind of now not relevant because you have a laparoscope now. See, that only would arise if you had to do just a disc and then bring out the loop, transverse colon or ileum. But when you have a laparoscope, you can actually identify the exact loop and then bring it out. So I think it is probably not difficult. Either of them is easy to bring out.
But actual fashioning, excuse me, actual fashioning, where you have to form the pout, is definitely more involved than doing a flat colostomy, but it's not much of a difference. Really, not much of a difference. It is fairly easily done. Vinod, you had some other questions?
Yes, sir. This in transverse colon stomas, you said you will
ಕಾಣಿಸೋದ
separate
ಮೆಶಾಕಿ
moment.
ರಿಪೇರಿ ಮಾಡಬರೋದು ಹರ್ನಿಯಾ ಏನು ಇಲ್ಲ ಅಂತ.
Hello.
Go on.
When omentum is separated, there won't be any chance of internal herniation, sir.
No. It's nicely, there won't be. That's all I can say, because the momentum will stick to the undersurface of the peritoneum, of the abdominal wall, and there shouldn't be a big gap. It depends on how much you mobilize. You mobilize just enough to bring the loop of the colon out. Okay.
And sir, this one, you said 2-finger opening should be there in the fascia.
Yes.
So this is same for end and loop, sir?
Yeah. It's the same for everything. The only exception is if you have inflamed, thickened bowel for whatever reason. If you have peritonitis and you bring, general peritonitis, and you're bringing out a very inflamed colon or inflamed ileum and inflamed omentum for, in a case of fecal peritonitis or general peritonitis, then this 2-finger breadth will not help because it's too small. You have to then look at what is a comfortable size and then bring it out. It's also true that in those situations, the incidence of parastomal hernia is higher. We will come to that when we come to that. There's a whole lot of topic on that. Okay. All right. Let's go to the Brooks ileostomy. The classical ileostomy that we do with a pout is called a Brooks ileostomy. All right, Sanya, tell me about how you would do it.
Sir, we have to first select a proper site depending on whatever factors we've discussed. And then again, we will start making a circular incision in the skin and through the subcutaneous tissue, either cut out the subcutaneous tissue or retract it and then go to the anterior rectus sheath, cut it in a similar fashion, either cruciate or a single incision, and then whatever muscle fibers are there, separate, retract the muscle fibers in the direction of the muscle fibers. Then we will reach the peritoneum and we have to incise the peritoneum, again make a 2-finger space breadth. And before doing the ileostomy, if at all we are doing a laparotomy, we would have selected a proper adequate the size from the ileocecal junction where we want to do the ileostomy, bring out that loop, because of since the mesentery is usually pretty big, so it is easier to bring out the ileostomy. If not, wherever there are adhesions, we have to release them and make it adequately mobile for it to come out to the skin surface. Once it is out, we have to make sure that the proximal loop is proximal and distal is distal, or
orientation.
We have to orient it along. Then we have to I have read about 2 different ways how we do this ileostomy. So one is make a transverse incision on the lower little more towards the distal loop.
Correct.
And then suture the distal loop from the skin to the edge of the bowel directly. Whereas the proximal loop has to be pouted. So start with the skin. Before this, a few places they told fix the loop to the rectus sheath with few sutures to the sheath, seromuscular, and then to pout the proximal loop.
So how do you pout is the question.
We have to take first bite to the skin, second bite to the seromuscular of the bowel that is little bit above or closer to the skin. Third bite will be through and through to the edge. So when you tighten, the cut edge will get folded upon and come close to the skin. That will give the pouting.
Is there any other way of forming a pout first before you finalize on the sutures?
Roll the edges, sir.
Yes, sir, manually.
How do you do it manually? You can put a Babcock
Back
Okay.
or back end of the this thing, tooth forceps also we can put in, and then we
Good
can.
force, yeah, doesn't hold it very well, I believe. But you can put a Babcock about 4 centimeters into the anti-mesenteric border of the ileum. Okay. And then fold it backwards over it. Then you form a good pout, and then you can finalize it with the stitches. 3 to 4 everting sutures, 4 to 5 centimeters from the end of the bar. Okay. You take it to the skin, the seromuscular layer about 4 to 5 centimeters proximal to the edge, and then the edge. So when you do that, then you are very sure what happens is that before you have put your sutures, you actually form the pout. You know how it looks. And then you're a little more confident that your sutures will definitely hold a pout in place rather than form the pout. You understand the difference? It does form the pout. I'm not saying no, but this is a more sure short way that you have a good pout in place and then just hold it in place with your sutures. Okay? Did you understand that?
Yes, sir. Yes, sir.
Yeah. Okay. So this is how a Brooks ileostomy looks. Again, we have not mentioned about the facial level sutures. I put facial level sutures there. There is a modification where, because you want that pout to stay as it were permanently, particularly in permanent terminal ileostomies, people denude that 4 or 5 centimeters of the serosa all around, and then do the pout with the hope that that pout sticks better than otherwise. I have never done it. Ravi, have you done that? Anything like that?
No, sir. No, sir.
No. Yeah, and I think it is not really necessary. Okay, this is how a good ileostomy looks. Nice 3 to 4 centimeter pout, and it's also one of the challenges that I have always faced is the pout must be facing downwards towards the caudad, towards the patient's foot. And sometimes that can be a challenge. Sometimes it may be facing upwards, which doesn't help much. In which case you can then reorient a little bit with the suturing. The way you do the suturing, it comes with experience. You can reorient it to look downwards. Okay. And this is a loop ileostomy. That is what I showed there was an end ileostomy. Here, as you said, in a loop ileostomy, you pull the loop out. And as you rightly said, Sanya, you cut at the distal end, not in the middle. If you cut it in the middle here, you won't have a pout. So cut it distally, and that's the point you mentioned, which is quite right. You can initially suture this distal end to the skin edge, or you need not. And you take your sutures in such a way that you form the pout. And what is this contraption called in the, sorry, go on.
What I have seen Muni Reddy sir do is he just makes an incision. He says we don't put sutures anywhere, sir. He says that the bowel itself will retract and like fold upon itself, and whatever proximal the contents will start coming out.
So are you telling me he forms a pout without sutures?
No sutures to distal or proximal end, sir. We bring out the loop, just make a cut like how we have done here, and leave it there.
How do you stitch that?
That's what, sir.
Do
That
nothing
stitching is not
except
done.
this.
Yes, sir. Yes, no stitching done anywhere except to where you fix it to the sheath.
Yeah, I think he will have to publish it because I have never seen that being done.
Because initially
I'm
I did
not saying
this
it in in any negative manner.
Yes, sir.
If he just cuts it and leaves it and it works
And all his
nicely.
none of the stomas have gone back, like it is not closed or reduced output, nothing, sir, no complication. All of them do have good output.
You should really publish it. Ask him to kindly publish it. It's really, really important that something like that can be done. But I find it difficult to understand how that cannot.
Yes, sir.
There were few cases of parastomal hernias and herniation. Sir's technique is very good, but what I have seen in many years, this thing, because of the weakness, since he doesn't fix it anywhere, there have been some herniations and outpoachings in
but then
few
how
of them.
will herniation be related to whether the stoma is like out, sutures are put to the bowel and the skin?
No, he
Herniation
doesn't
will
fix.
be...
He fixed it only in few places there. So he doesn't fix it in many places. So that is a
Okay.
No, sir. What I'm asking is, sir, does as far as I have seen, sir, does fix the bowel to the sheath,
There are two
which
issues.
we are done every.
There is no connection with respect to this. What he's is, he doesn't any places. No. So
Yes, sir.
there,
What I'm telling is, sir,
the
doesn't fix
parastomal
this bowel to
hernias,
skin
I have
sheath.
seen in quite a few places.
All right, Sanya.
Okay.
The
Yes, sir.
other issue here is
That
How will the pout
he
form?
doesn't fix.
Sir, that's
Yeah.
what sir
He
says
says it
that the
doesn't
pout
need a
will form
pout.
on its own.
Yeah,
Sir
it
will
won't
say
form. He says
once you
it,
open the
pout cannot
proximal
form.
contents.
Pout cannot form, Sonia, but he said that's not required.
Yes, sir,
That's
that's
a
not
point.
required.
But the other important thing is there must be a mucocutaneous connection for a
Yes, sir.
good. This will be applicable only for a temporary ileostomy. It can never be used for an end ileostomy because
Yes,
that
sir.
bridge you cannot remove, which we normally do. That's a bridge. This is for
Yes, sir,
temporary
yes.
ileostomy. The other important thing is there must be a mucocutaneous continuity. And this kind of non-suturing may hamper that. And that in fact,
sir.
theoretically leads to a higher incidence of skin complications.
Skin
And,
complications.
Recently,
Yes,
one
sir.
patient had a severe skin excoriation.
Yes, sir,
sir.
that is true.
skin complications and what we call
No, but the
stoma
contents can
edge
also
abscess. Yeah.
content can leak into the space
Into the
and cause
facial, into the layers of the abdominal wall, right? So in fact,
Sir,
we will, when you look at complications, we'll discuss it further. Okay.
Okay, sir.
Sir,
Okay,
Yeah.
sir.
sir
So-
will do it in proximal segment towards the lateral side, sir, and the distal segment towards the medial side, towards the umbilicus, and the division will be towards the lateral end.
we are having too much of a discussion on what I can respectfully say is a non-standard procedure.
Yes, sir.
And
Okay,
we have
sir.
to make it standard by publishing.
Yes.
Okay, so I think we'll stop here. But this is the standard, and if you answer this in an examination, you will be in trouble.
Yes.
That much I can.
Sir, number of sutures, sir, to fix it?
It depends on the size of the bowel, but usually about 8 to 12 all round. Okay, and what is this thing called? In a loop colostomy or an ileostomy, there is a contraption here. What is that?
just now told it to you.
Yeah, I even mentioned, gave the answer. What is that called? Sanya, it's called a bridge. Okay.
Oh, yes. Okay, sir.
It's called a bridge. And what you do it and put it across the skin, across the stomal
sir.
aperture, and stitch it to the skin, close to the
Yes,
skin,
sir.
and cut it off. So you can use anything there. There are what are called Hollister bridges, which are very expensive, which clip into place, and it's, I don't know, 1,000 or 2,000 rupees, completely unnecessary. You can use a Riles tube and stitch it to the skin head. You can use a Foley's catheter. You can use a large feeding tube or whatever. And that stays there for about 10 to 14 days until the adhesions occur and the stoma can stay by itself. If you do not have a bridge in a loop stoma, sometimes you can have the whole stoma getting in, retracting. And this is one insurance against that, as well as the facial stitches that we put. That will help you prevent both retraction and prolapse. Okay, so this is called a bridge, and you can use anything that is readily available in your OT to form a bridge. Okay, and this is how it looks. So you, in a loop ileostomy, you have this, the distal non-functioning end flush and the proximal functioning end, which is a pout, and a bridge in between. So we call something a mucus fistula. What is that? And when would you want to do that?
In an end stoma, sir, say for example, distal mucus fistula we make if there is the.
Tell me, what is a mucus fistula?
So it is something, whatever the secretions of the large bowel, that mucus content
All right.
that comes out, not the actual
fecal content. Correct.
Yes.
Okay. So when do you envisage that situation? When do you see a situation where one end of the bowel, you have one terminal stoma and and the other end is brought out.
Double barrel kind, sir.
What is the difference between double barrel and mucus fistula then?
Okay, two different stomas separately, sir.
Double barrel is next to each other, but there is complete division of the bowel, unlike in a loop where the posterior wall is still intact. Okay, but in the double barrel, both loops, both stoma come out in the same hole. Yeah. So what is a mucus fistula then?
Sir, the non-functioning part of the colon is brought out.
Correct.
Basically,
I am asking you, where do you give me an example?
Sir, in a trauma
Crohn's,
case,
IBDs.
Okay. What would you have done to give you two holes, one quiescent, one non-functioning, and one functioning? What would you have done? Very simple. If you have a perforation of the right, it can happen in any colon. I'll give you one example. Perforation of the right colon, maybe from Crohn's, maybe from a perforated cancer, maybe from trauma, with peritoneal soiling. You don't want to do an anastomosis. So you do a resection. So you're left with two holes. One is the terminal ileum. You've done a right hemicolectomy. Okay. There's a terminal ileum and you have a transverse colon. So what do? You have to bring both out. Okay. And that is a mucus fistula. So typically this is what happens. You bring out an ileostomy and a mucus fistula can be brought out through the main wound because it's not spewing fecal matter. So you can bring it out through the main wound, and this is exactly what I've done here. This is the main wound, this is the mucus fistula, and this is a terminal ileostomy. At an appropriate time, you can re-laparotomize the patient and put the two ends together. Questions?
Why, sir?
Sir,
Why to get the distal end?
Why not? What other choice do you have?
Just close it and keep inside.
Close it and keep it there. What are the problems that you envisage with that?
It can
Maybe,
start leaking because of
Yes,
excess
it
mucus
can
collection,
start.
sir.
Yes, it can start leaking. What else can happen?
difficulty in anastomosis.
That
sir?
itself can form a fistula by itself and come out of the skin, sir.
That can give you
Enterocutaneous fistula
you end
kind.
up with and the second thing is you in those many situations like this, you're not sure how well it will go beyond and come out of the rectum. Okay, you haven't seen the situation. If it's an emergency, particularly. Okay, so the safest thing is instead of risking suturing and a suture line breakdown, the safest thing is to exteriorize it. Okay, you can do the same thing with the ileum also. There will be an ileostomy which is working, and the distal ileum, which may still be there, can be brought out as a mucus fistula if you have done an ileal resection, for example.
So suppose if we did do not considering the soiling or anything, if we had done an ileotransverse anastomosis also, then how will the contents pass distally, sir? Like, because now we are thinking even if we close this transverse colon and leave it, contents are not going to pass distally. That is why we are doing a mucus fistula.
That's one of the reasons, not the only reason. The main reason is a suture line breakout. But one more reason is if you do not do an ileotransverse colostomy until you're damn sure the distal end is okay. You will not do it. So at laparotomy, you would then explore everything, make sure that everything else is okay. Only then do an ileotransverse anastomosis.
And sir, other thing is in patients with the toxic megacolon or very bad colon and the rectal stump, there is a very high chance of blowout if you close it. Even though you can do a mucus dilatation of the anal canal, still it can blow out and cause severe sepsis. And that is very inflamed part of the bowel. So you are better off bringing it out as a mucus fistula.
Yeah, that's exactly what I said. When you have an inflamed bowel, edematous bowel, chances of your suture line breakdown are high. And so you bring it out. That's all. So,
sir,
yeah.
Two questions, sir.
Yeah.
One, if it is good enough to make a mucus fistula, why can't we directly make a stoma there only, like excluding the ileostomy overall?
Hey, how can you say that? That's a distal non-functioning end, madam. This is the functioning end. So you have to have an ileostomy.
We have removed the whole of the right colon here, Nikita.
Yes, yes.
Okay. Okay.
Yeah.
And second one, sir, there isn't any stain of the colostomy bag at the mucus fistula. Is it just open to that, or do we actually
Yeah,
put a
we
bag over
just,
that?
no bag, because it doesn't do
Okay.
anything. We just put a little gauze piece on it.
Okay, sir.
That's all. It hardly produces anything. Yeah. Yeah. It will produce a lot of mucus if there's a distal blockage. And as I said, even though we don't look at all that in an emergency situation, fecal peritonitis, inflamed bowel, everything. So the safe thing is to just do a mucus fistula and get out, so that you're sure that you'll have no further problems. And usually the contents of the mucus fistula are so minimal that it will not need a bag. Okay?
Yes.
You got that? Yeah. So tube cecostomy, I'm just going to run through these. Very rarely done, usually done for incipient rupture of the cecum in a left colon cancer or a stricture. Okay, good. A simple question to Samir. Why would the right colon perforate first when you have a left colon blockage, Samir? Manas. Nikita.
Ileocecal valve, sir.
No. See, this
Wall thickness.
cecum. Somebody is talking here. Yeah, go on. What else? Go on.
Wall thickness, sir. As we progress towards the distal end,
All
the
right.
thickness of the wall.
That's one. Anything more important than that?
And bacterial.
No. So all of you must go home and write the answer today. It's an extremely important, simple question which we'll all learned as undergraduates, and I'm a little surprised you guys didn't answer. It has to do with physics law, a law of physics. Okay, somebody whose name start with L. All right. So read up about it and then write to me. Okay. So cecostomy, you can put a tube cecostomy where you can't bring the bowel out to the abdominal wall surface. Okay. But it can only use it in liquid feces. So you can put a tube into the ileum if you want. I have never done it. The only small bowel tube I have put is a formal duodenal fistula for duodenal blowout, duodenal stump blowout after a gastrectomy, not in the terminal ileum ever. You can do a Foley's or a Malicos into a cecum and bring it out. But as I said, it's not something that I would do. In the cecum, it can be mobilized well enough to be brought onto the surface. So if you ever do it, I've done it on 2 or 3 occasions, very rarely, where actually I've exteriorized a little ruptured area of the cecum in a left colon as an emergency. Okay, so tube cecostomy is something that is rarely done, but it's something you must know about. A formal cecostomy, as I mentioned here, is always preferred. And open gastrostomy is practically unknown now. Go on.
There was a practice of on-table lavage. So an on-table lavage for distal descending colon or rectal or sigmoid tumors, when you resect that and then you do an on-table lavage using the appendix.
Appendix stump. I've done a lot of those in Aberdeen.
Yeah. So, and then because you put the tube already, instead of doing a stoma, many people actually brought that out as a insurance purpose, and then hopefully once the anastomosis is working, pull it out.
Yeah.
But very rarely, as you said, that is the only thing I have seen where you can use a tube cecostomy.
Right. Even though I've done a lot of on-table lavage, I've never brought it out, but it's something that can be done. Yeah. Open gastrostomy is really very rare. Okay, it's all PEG now, PEG, percutaneous endoscopic gastrostomy. Even if you have severe esophageal stricture, many times we can dilate it endoscopically, but you may have some situations where you can't dilate it at all. If that happens, then you have to do an open gastrostomy. If you have gross ascites, it is a contraindication for PEG because you can't bring the surface of the serosal surface of the stomach onto the undersurface or the peritoneal surface or the abdominal wall. So you can't do, it's contraindicated. So these are the two situations that we may have to consider an open gastrostomy. Of course, you can use it for decompression if there are distal blockage or ileus, or for feeding if somebody was not feeding. Okay. There are two ways of doing it: the Witzel gastrostomy and the Stamps gastrostomy. You basically the Witzel, the same principle is seen and is used in a feeding jejunostomy also. So you can bury the last 3 to 4 centimeters of the tube in a serosal tube, as it were, like suturing it like this, and then the exit hole of the tube is 3 to 4 centimeters away from the entry hole of the tube into the stomach. Or you can do a double layer or a circumferential purse string suture to get that burial of the tube required. That's called a Stamps gastrostomy. But as I said, these two are very rare. Esophagostomy is something which is rarely ever done. I have seen in all my life only 2 cases, the 2 in America, and where it would never have been done in the UK. Okay, it's difficult to manage, it's cumbersome, you have to have a bag there. And sometimes people would use it for an esophageal leak or a perforation to divert the saliva, but that has become unnecessary now because you can even put a stent, endoscopic stent, across a possible leak in the esophagus. And so you don't have to have diversion of saliva. And the 2 cases that I told you about were sham feeding. People with inoperable carcinoma esophagus, they couldn't eat. So just to give them the satisfaction of eating, they would do a esophagostomy. They would eat here and it would come out of the neck. Something that is completely, almost condemned, as it were, in the UK. We have discussed it there when we were talking in the surgical circles. It was never done because these are people, when they're so advanced and so uncomfortable, they need palliative care. Okay. And so if somebody insists for medical legal reasons, maybe you want to do a TPN, but this sham feeding is something that is hardly ever done. Ravi, your comments on this?
Bailey and Love mentions that even for CA esophagus, it is a crime to do gastrostomy because you let them, palliative care, let them die rather than just keep them alive.
True. Yeah. I'll stop here. It's 20 past 10. It's going on. And actually, the discussion was good, but it took longer than expected. We still have a lot more ground to cover, as you can see. We will talk about the quality of life and other things in the subsequent class. Questions, doubts from the students? Comments also?
So nothing in specific, sir, now.
Yeah.
I think we'll have more questions in the complications part, sir.
All right.
Sir,
Registrars. Sorry?
Is it Laplace law?
Yeah, you know how to see Google. It is Laplace's law. All right. I want you guys to read it and put it in the group. All of you read it properly. And it has to do with the radius or the circumference.
More the radius, more is the pressure.
Yeah. And what is the relationship? Is it linear or what is it? It is not the pressure, it is the tension. All these things you have to learn tension completely. Wall tension. Tension is what tears it, okay?
Yes, sir.
So is it a linear relationship? What is the relationship? What does it say? It is the square of the radius. All right? Okay, write the Laplace's law properly and then all of you read up about it. That is why the cecum bursts, even though the obstruction is in the left colon. Okay? Yeah. The tension in the wall is equal to or is related to the square of the radius. And the cecum is the most capacious part of the large bowel. That's why you have perforation in the cecum. Okay? All right. But please read it properly and write everything, all of you, in the group. All right. Niranjan there. Closing comments,
Yes, sir.
Niranjan?
Sir, it was a good discussion, sir.
Yeah.
We have covered most of it.
Yeah. Ravi, closing remarks.
Yeah, as usual, it was very informative and very, a lot of discussion, and I think a lot of doubts were cleared. It's essentially extremely useful class. Thank you.
Thank you very much. Good night, folks.
Yes.
Good night, sir.
Good night.